And the reason we're talking about those things rather than the harder things is because it's easy politically. I don't think the economic crisis is fundamentally going to change that, with one exception, and that is there's going to be tremendous fiscal pressure on Medicare, as Jim was indicating. And among other things, Medicare is going to lose a lot of payroll tax revenue because of the decline in the economy, and that is going to push forward the insolvency date and the trust fund for hospital insurance. So I expect within the next couple of years there's going to be a crisis in Medicare financing, and that is going to in turn generate pressure to control Medicare spending. And the way that Medicare knows best, it may not be the best way, but the way that they're most familiar with is exactly what we've been discussing, which is tamping down on prices.
Are there other options that you see us turning to as we give up on the easy things and begin to do some of the tougher things?
Never underestimate the ability of the American healthcare system to avoid unavoidable decisions. And there have been many times in the past when people have said healthcare costs cannot possibly go past this number, and because of this recession, we're absolutely going to control costs. And each time we've sort of glided by, and we've hit bumps in the road, but we tend to bounce back in terms of healthcare spending. I really think that in the short term, politically, nobody wants to tackle costs.
Meredith, you've probably done more, hardcore research on the impact of various payment models. What do you see happening now in terms of payment reform? Might it accelerate the adoption of new models? Might it slow it down?
Well, so I suspect that it'll be somewhat of a mixed bag. I think there are a couple of different ways that payment reform can play in here. If you think about worries about avoidable complications, for example. As you know, Medicare has revamped the way they pay hospitals so that hospitals aren't effectively rewarded for causing bad things to patients, like infections and that sort of thing. And so I think a lot of payers are going to look for opportunities to pull back some perverse incentives that may cause hospitals, physicians to actually take care of some avoidable quality problems. But unfortunately, most of the ways that we know to reduce infection, to reduce errors, adverse consequences, involve investments in information technology and quality improvement. And it's not clear that the provider sector, just having the right incentives is enough. They may need additional capital, and as Jim said, it's not really there to make those investments. I think there are a number of other payment reforms, like the patient-centered medical home and the notion of altering primary care physician payment to support the patient-centered medical home, that really are about providing additional upfront dollars to re-engineer the way physicians practice care, with the hope that in the long run, care will be higher quality and less wasteful. But those kinds of upfront investment payment reforms, I think, it seems to me that they're going to be off the table.
John, what's your sense of the prospects for payment reform for Medicare?
Well, there is an interesting opportunity, and that is the physician payment formula in Medicare is broken and widely acknowledged to be broken. And they're going to have to come up with a fix within a year. It is a very expensive fix, $300 billion expensive over 10 years. But there is some thought in Washington right now that they may use the opportunity to fix Medicare physician payments in the sense of exploring some of these opportunities for payment reform. The problem, and Meredith has written about this, is we don't really have a magic bullet in payment reform. What we tend to do in payment reform is go from one favored solution to another favored solution. None of them sticks around very long, so we were into pay for performance, and now, as Meredith has said, we're beyond pay for performance. We're trying lots of other things. I'm not sure there's a clear winner in there. I think there is a chance in the stimulus bill to do a little bit of investment. They're talking about at least $20 billion in health IT. Whether that money is going to be well spent, I have no idea. I think that the more important question to me in the stimulus package is, are we going to do anything for the uninsured? And right now, it looks like the efforts are going to be modest as part of the stimulus package. One thing that they absolutely have to do, and that is give states relief for Medicaid.
Jim, turning back to the new payment models, how do you see providers looking at payment reform from Medicare? What will it take for them to look favorably upon them, or at least not rebel if they're rolled out?
I would say that that the more forward thinking and looking providers recognize that the current reimbursement system is broken, that unbridled fee-for-service is an engine for inflation, and that consequently some kind of reform is necessary. I think all providers instinctively shy away from kind of the blunt reforms of we're just not going to pay any more than we did last year or pay 5 cents less than we did last year. We all see this spectrum of fee-for-service on the one end going over to capitation on the other. Many of us, I think, rationality would drive us to capitation, but we recognize there are big political issues with choice on consumers' part and still remaining technical issues about setting the rate. The in-between has been the vast terra incognita of pay for performance, case payments, bundle payments. But I would say if you're talking about payment reform, you almost need to get at some degree of more integration of the system, because under a very fragmented system, it's very hard to reform the payment. You don't know who to give the case reimbursement to or who to give the bundled payment to. And so I think the linkage between the need for reimbursement reform and the need to somehow move from an extraordinarily fragmented health system to a system that's got some degree of integration, I think those two things have to be approached in tandem.
Well, I think this chicken and egg problem between payment and organization, that's precisely why I worry that a payment reform under the conditions that we're facing now just is unlikely to have the right formula, because I think we do need to invest in either infrastructure or communications, the kinds of things that can make practices and hospitals integrated at least virtually in order to apply the payment models that are most likely to have the most success. And so I really think that requires upfront investments and a willingness to wait for the returns. And there may be a little bit in the stimulus package that moves us in some of that direction, but there's probably not going to be enough. So I do think that's the right way to think about it. I think probably 2009 is not the year that we're going to see that kind of investment.
This is not a new conversation. In fact, if you go back and read the reports that committees did on healthcare costs in the United States in the 1930s, they also talked about the fragmentation of the healthcare system. I think it's a very difficult thing to move away from. I think the experience of the Veterans Health Administration has demonstrated the benefits of integration, and really they have gone from the back of the pack to being the leader, at least in some respects, in delivering organized care in the United States. But politically, it is very, very difficult to move to that kind of system. We can't do everything in healthcare reform. To me, the most important thing we can do for any of this effort is to expand coverage and move towards universal coverage in the United States.
Do you see any silver linings in the cloud?
I do. I think, if it rains enough, we might have to build an ark. In other words, I think if the situation in the healthcare system gets sufficiently bad, it may compel action. And we don't know, sitting here right now, what the economy is going to look like 6 months, 9 months, a year from now. If it continues in this tailspin and there is a tremendous amount of economic insecurity in this country, healthcare is a very large part of that. And there will be momentum for health reform. But I actually think this is the most optimistic time for health reform in the last 20 years. So I think there is a chance. There is a chance.
I have, in conversations in Washington with the health plan and employer stakeholders that I spend most of my time with, have gotten a sense of a willingness to compromise that I certainly have not gotten in the past. And I think the same is true on the provider side. I see a very productive dialogue going on between providers and payers that do sort of recognize that neither fee-for-service nor capitation is likely to be the solution, and that something in between is the right idea. To get both sides agreeing on that, I think, is incredible progress.
I'd be hard-pressed to find some silver lining inherent in this current financial debacle, and I have a hard time, frankly, linking that to the way we get things fixed. And I worry sometimes. I appreciate the ark analogy, but a lot of people drown before the ark gets built, So I remain pretty pessimistic about the difficulty of the job ahead of us. What keeps me optimistic and going is I do think that the work in medical science is going to be spectacular over the next couple of decades. Ultimately, I think that'll increase pressure, that people are going to want the right kind of health care, and will force us to figure the right kind of solution so people can get the fruits of all of these advances.